Good day. This is a webinar for the neurosonography, the scanning of the neonate brain. My name is Nadia Alfonso Jean-Denis. This is for the obstetric class sonography 2 at Eastern Florida. To begin, I want to give you a little introduction. Cranial sonography has been a really important part of neonatal care. Why is that? Because when we have really high risk, unstable premature infants, we want to make sure that we can evaluate them in a safe and rapid way without needing any sedation or any other risk. Why are we doing brain scans on neonates? What's the reason for? It is to follow up on intracranial hemorrhage, hydrocephalus, and PVL, also called periventricular leukomalacia. So here's going to be a little outline on what we are going to talk about during this webinar. First, why do we need a neonate brain scan? We're going to talk about a little bit about the anatomy. We're going to talk about the type of transducer we're going to use, the protocol we need to follow. What are we looking for when we're doing the brain scan? Looking at examples from what is normal and what is abnormal. Going to have a little quick summary with a post-test, and we're going to review and check our answers and a little reference page. So let's get started. So here are some reasons for the exam. The number one reason for the exam, or the most common reason why this exam is ordered, is for prematurity. Premature, it has changed over the years, but as of right now, premature is considered a neonate infant less than 37 weeks. We're going to do that because we're going to check for hemorrhage due to increased blood pressure, due to the fragile ependyma. We also scan babies for a neonate scan if you see an increased head circumference. A persisting large fontanelle. Also, if we see a premature closure of sutures, trauma, of course, known hypoxia, follow-up on a known pathology that we may be encountered on an anatomy scan during pregnancy, failure to thrive, and if we suspect any intracranial mass or infections. So those are all reasons why we would order a neonate brain scan. So here are the transducers. As you see, for the neonate brain scan, we have two transducers listed. We definitely want to do the same protocol with two different transducers. Why? Because different transducers have a different window. What one gives us, the other might not, and vice versa. So we want to make sure that we don't miss anything, and that's why we're using the two different transducers. So one will be, the one that you see to the right will be a high frequency linear transducer, and the other one will be a small footprint, a wide sector mid-frequency transducer. So once again, we're using them so that we have different windows and we make sure we don't miss anything. And we are repeating the same protocol twice. Now, when we're scanning the neonate brain, we want to make sure that our little patient is on the supine position, laying on its back. Also, it is mostly beneficial if actually the infant is sleeping or resting. Um, we're going to, I've seen it either way. You can start the protocol sagittal or coronal, and then vice versa. Now, first you want to scan, as you see in the pictures. From the top of the head, you find the midline. You scan the sagittal, and then you sweep right lateral and left lateral. And then you're going to go on the coronal, and you're going to sweep anterior and posteriorly. And we're going to go now look at the anatomy. When we take those images, what do we want to make sure of that we can see? We want to make sure that we can see the two lateral ventricles. How do they look? Or the anatomy of the two lateral ventricles, they are cerebrospinal fluid filled cavities. How do they appear on our screen? How is the sonograph appearance? So the ventricles, the lateral ventricles appear very echogenic and curvilinear. The ventricles have a cavity, and they contain our CSF, our cerebrospinal fluid. And that fluid appears anechoic. Next, the third ventricle. It is very tiny. It's shaped like a teardrop. It has a midline cavity that lies between the thalami, and it's connected to the lateral ventricles via the foramen of Monroe. The sonographic appearance, we have the walls being echogenic, and the cavity contains the CSF, and that appears anechoic. So you have the little arrows pointing to it for the fourth ventricle. The fourth ventricle, it's also very small, like the third ventricle. It's arrow-shaped, and the midline cavity appears to project into the cerebellum. How's the sonographic appearance? The walls are also appear echogenic, and the cavity contains again the CSF, and that will be seen as anechoic. Next, the cerebellum. That one is the second largest portion of the brain. It is posterior to the fourth ventricle, so the fourth ventricle is anterior to the cerebellum. It looks on our image, the parenchyma looks mid-gray, kind of medium level echoes, and the central echogenic portion, that is where the vermis is. Now let's look at some other anatomical structures that we're looking for when we're scanning our images. So we have the cisterna magna, that is the largest expanded space in the brain. It's located in the base of the cerebellum, and I have a picture right there on the right side that's labeled CM. Sonographic, as you can see, the cavity contains CSF, the cerebrospinal fluid, and it appears anechoic. Choroid plexus, I have the picture in the bottom right. Those are special blood vessels located in the ventricles that actually produces the CSF. How does it look? It's two curvilinear, highly echogenic structures that arch around the thalami, anteriorly from the floor of the body of the lateral ventricles. and posteriorly to the tip of the temporal horn. Note, it does not extend into the frontal or the occipital horns. So there you see this highly echogenic area that represents the choroid plexus. We got the foramen of Monroe, and that one is a narrow midline channel that connects the third ventricle with each lateral ventricle for the passage of the CSF. How does it look? It's an anechoic area just posterior to the level of the frontal horn of each lateral ventricle. And then the brainstem. This is more a columnar appearing structure. It connects the forebrain and the spinal cord. It connects the midbrain pons and the medulla oblongata. So sonographically, it's mid-gray with medium to low echoes. So a little bit of a variety of echoes we see in the brainstem. Now that we know how our anatomical structures look like, let's get into the protocol. We want to make sure that we use sufficient gel. We don't want, this is not an abdominal scan. We want to make sure that we do not put too much pressure at all on the baby's head. So we want to make sure we use sufficient gel. We usually go to the anterior frontal, and that's where we're going to start the scan. Now, we're going to use two different probes. Remember, we're using the high frequency linear probe, and we're using the small footprint dissector probe. So we can begin in the coronal plane, slowly sweeping from anterior to posterior, and then we rotate it 90 degrees to perform the sagittal and the parasagittal views, meaning sweeping right and left. And then we're going to repeat the same thing with the high frequency linear probe. Now make sure when you use the linear probe, you should access the superior sagittal sinus, and you will be able to scan as deep as the third ventricle when we're using the high linear probe. Now, what are we looking for in the sagittal view? Midline, we gotta make sure we include the corpus callosum, the third and the fourth ventricles, and the cerebellum. Parasagittal, we wanna make sure we show the details of the lateral ventricle. So that's when we sweep right and left. And we wanna make sure we show lateral, we're gonna show the white matter. Coronal, what are we looking for in our coronal view? We're looking for the frontal, the caudate region. We're looking for a series of images in the caudate region to the trigone of the lateral ventricles and the occipital region. So those are the things that we want to make sure that we have images when we take our images in the coronal view. Now, normal versus abnormal. I have some sagittal image. To the left, you see a sagittal normal brain scan of a neonate. To the right, abnormal, as you see where the arrows are pointing to, you see a hemorrhage. As you notice, an hemorrhage on a neonate brain scan appears more echogenic. It is not anechoic. When we look at normal versus abnormal here in the coronal, once again the left is normal, and as you see, look at the right, abnormal. You can see the hemorrhage. Also, you see it by the lateral ventricles. You see a very echogenic area, and that's definitely something that's pointing to a hemorrhage, something we don't want to see. So that is the abnormal scan to the right, showing an echogenic area. And remember, that's how you will see a hemorrhage. It will be echogenic. Now, summary. A neonatal head CH should be concluded in two different views, coronally and sagittal. Coronally anterior to posterior, sagittal from left to right. Now, we want to make sure when we find a pathology, like you see on my abnormal versus, I showed it to you in two planes. You definitely want to prove it, and you want to check for vascularity, and you want to make sure that you measure it. So measure it, show vascularity, and you want to show it in two planes. You want to prove it. Complete the protocol using two different transducers. Remember, we want the two different windows to make sure we do not miss anything. And know you're abnormal and know you're normal. What's the difference? How should it look? Now here are the post-test, and I want you to think about the following things. What is the most common reason to order a neonate brain scan? And how many planes should the abnormalities being taken? Why should you use different transducers? What is considered a premature infant? In what planes does a neonate brain can be conducted? What type of transducer should you use? And what do you look for in the sagittal plane of a neonate brain scan? How does a hemorrhage show on a sonography on a neonate brain scan? Which ventricle is being described? All right, a small ventricle, teardrop shaped, in the midline cavity that lies between the thalami and is connected to the lateral ventricles via the foramen of Monroe. Walls appear echogenic, cavity contains CSF and appears anechoic. So what ventricle am I talking about? And the last question, which picture shows a normal neonate brain scan? And here are the answers. You definitely, the reason is to check preterm neonates for brain hemorrhage. Number one reason you should, images of abnormalities should be taken into views, coronal and sagittal. We want to make sure, why are we using the transducers, the two different transducers? Because we want to make sure we don't miss anything. We have two different windows. They both have different advantages. And we know that premature is anything less than 37 weeks old. What planes should we conduct a brain scan? And that will be in coronal and sagittal. What type of transducer do we use? We use the linear and the small footprint linear sector. Linear transducer and the small footprint curve linear sector. What do we not look for in the sagittal view of a neonate brain scan? The one that would be the occipital region, and that will be not in the sagittal, that would be in the coronal view. How does a hemorrhage show on a neonate brain scan? We talked about it is very echogenic. Another word for echogenic is hyperechoic. And we also, for which ventricle is being described, the small ventricle that was teardrop shaped, that's in the midline cavity, that is the third ventricle. And if you go back to the pictures that I showed you, let me go back real quick. Picture A shows the normal image of a neonate brain scan. And that is the end. I hope you enjoyed it. And if you have any question, let me know. I'm at Eastern Florida at Dr. Holder's class. And that will be it for our webinar on the neonate brain scan.